Or finance.
Okay, great.
Great.
So Jill, I guess we'll turn this back, we're turning this down to Mara, right?
Yes, I believe.
Okay, so I'm the speaker that everyone is waiting for. I don't have a presentation.
Oh, okay.
As we go along, we are in a different room from where our printer is, so if you want to submit questions, I have 3 here. I will talk briefly about what the requirements are, and a lot of them are similar. So all of you are participating in our Health Choices program today, so everything is similar. I will tell you all that we are managing the PPS side for community health choices. We will work similar to how we do on the behavioral health side through the Office of Long-Term Living when we identify non-compliance or potential non-compliance between the plans and the health centers. So it's a little bit disjointed on how we contact the plans, but we will be getting all the information directly from the FQHCs. So for the 2018 implementation, some of those of you out there, everybody's at a different level on the number of patients that you see that are dually eligible, and that is our big population that we get questions on pretty frequently. If you have already been in contact with my staff, we have been doing some ad hoc reporting from the Southwest Health Centers related to CHC. We are planning to formalize and issue out a wraparound report for CHC with the next packet of wraparounds, which include your MEI increase. I would say that timing is set for late December, similar to the usual release of templates, and will include a CHC template. One notable difference in the CHC template is we've added a line for the Medicare revenue reporting. So similar to all of our other managed care operated plans, CHC is requiring the PPS rate be paid. And this is because a lot of the members that are, almost all the members that are going in were covered previously by fee-for-service. And in fee-for-service, you were able to bill Medicare first and submit for PPS rate to Promise. So we're making that transition similarly in CHC. So all of the CHC plans are required to pay the PPS rate set by, your PPS rate set by the department. We do issue them a report that shows what the PPS rates are currently. And we do, for those of you that have a change in scope, we do issue them notification on any retroactive change in PPS rate. So for those of you participating in the Southwest zone, they would be required to cover any PPS rate change back to January 1, 2018. For those of you that are looking to participate in the Southeast zone, that will be any change back to January 1, 2019. So I'm going to pause in case you're pondering and you want to submit questions.
Should they also be providing any change to the MCO?
Yes, we always request that you submit your letters to the MCOs. So we do have 2 sister MCOs. They are actually the same MCO, but we do not necessarily work with the same individuals between Health Choices and Community Health Choices at the plans. I'm not sure how it works because I know that you all work with your provider representation. We work with the financial staff. So we do request that you submit to your provider rep for Community Health Choices your rate letters as well when you have a change in rate. We also communicate that to the financial staff, and both UPMC and AmeriHealth do also participate in our Health Choices program. So there are similar people working on the effort, but not the same people. So if there are issues, you should let us know. Is the issue CHC or is it Health Choices or both? So for reporting on the dually eligibles, you would submit your invoice, your billing to Medicare. Medicare will make payment. In submitting billing to the CHC MCOs, I know I used the acronym, but that's, if you email me, that's what we would see. The CHC MCO, you would submit the T1015 billing code. So for those of you that heard me speak at the annual conference, please do not submit for a PPS encounter any other code. When you do that, we're not able to provide help to you on the back end because we also get encounter data. Yes, the Community Health Choices MCOs do submit encounter data to the department, and we utilize that to also do assurances to make sure that they're paying appropriately. So if they're giving you direction otherwise, please let myself, let Lori know that you're being given different direction. But you should be billing for a PPS encounter T1015, T1015U9, and if you're doing any other services that will require a modifier, so remember behavioral health, Health Choices pays on the other behavioral health modifiers. There can be some modifiers other places, but it should be T1015, T1015U9 for CHC. Again, I'm going to pause in case you're pondering and want to submit questions. So you would then submit, along with your billing, your Medicare explanation of benefits that shows what Medicare has paid, so that the Community Health Choices MCO is similar to the other MCOs, able to reduce their payment by the following. They can reduce the PPS payment by the revenue you receive from Medicare, and if the individual has an MA copayment, that MA copayment is then reduced. So we do get questions today in Promise on why the PPS rate is additionally reduced. For dually eligibles, some of them do have copayments. So in this population, you have to factor in both the MA required copayment, and I think we have a max of like $6 in MA for copayment, and the Medicare revenue.
Can you say that one more time?
Yes. So for this population, most of them do have a copayment obligation under MA. So your payment that you should receive would be the PPS rate less the Medicare revenue, less the applicable MA copayment. And that MA copayment is required for the patient to pay at the time of service. Okay, again, I'm just giving some pause to, we are getting questions coming in the door, so. So when you're submitting wraparounds to us, we are including fields for you to be able to record all of the revenue. But again, the key piece here is make sure you're billing T1015. If you're being instructed to bill other codes, you need to let us know, because we're not able later to look into the data and make some validation on where you paid appropriately if you do not bill T1015. Okay, so I'm going to go through a couple of questions that I received. I have quite a pile. Are MCOs, CHC MCOs required to pay the Medicaid PPS rate minus the primary Medicare payment, or do they only cover the cost sharing or Medicare copayment? So I think I already answered that. You do also need to factor in the MA, the medical assistance copayment that's required. Will we still be able to bill for primary care for duals that are required to choose one of the 3 plans? If so, is this temporary, or will we be able to continue that indefinitely? So you should bill Medicare for the services that you're providing and any other third-party liability that would exist for that patient initially prior to billing medical assistance. And that's regardless of any plan that they choose out of the 3 plans. You would be required to bill Medicare first, or any other third-party liability. Is there any anticipation that the FQHCs will be required to contract with all 3 entities? So the Community Health Choices agreement language requires the MCOs to have a provider contract with all FQHCs in the zone in which they operate, so they're all 3 operating in the Southeast zone, that will accept the PPS rate. So as I told you about Health Choices when we came up, you should be expecting those contracts or any changes to your provider contracts to clearly state that they're required to pay your PPS rate for the services that are eligible under the PPS policy. So anything that's eligible to generate T1015 should be paying PPS, and I would expect that they would clearly document that in your provider agreement. So I think, I'm looking at Jill, I think we're expecting that you would be approached by all 3 plans.
Yes.
You don't have to have a contract with all 3 plans if you as the FQHC choose not to. If you choose not to and you're having an issue with getting a contract with one of the plans, you should let Jill know so that we can have a conversation with that plan, because they should be paying your PPS rate. So if there's a disconnect on what their understanding is and what they're telling you, we want to make sure that we have that discussion with them.
I think the other point, if I'm correct, the provision in the physical health choices that even if you're seeing a non-attributed patient,
I don't know that off the top of my head. I will need to talk to Jill. We added language about the patients not allowing denials for patients based on PCP, but I'm not sure exactly what's in theirs completely. If they mirrored ours, yeah, we'll have to follow up with that.
I think it is.
I think they have exactly the same language, but it's been a little while since I looked at her contract.
Yeah. While we're going, I'll look it up. But if it's in, it only applies if you have a contract with that CHC MCO. So it would be another reason to consider contracting with all.
Yes, if you don't have a contract, if you have a dually eligible patient, you are seeing them for Medicare, and you do not have a contract with their CHC MCO, we will require you to seek out-of-network payment with that MCO. So that is a recent answer that we've given on the Health Choices side. So you would have to contact that Community Health Choices MCO to get their requirements for their out-of-network payment. We do not necessarily know that for emergent services. There is a requirement on the payment level.
Yeah, they have to pay it.
They have to pay the fee-for-service amount, which is your PPS rate.
Right.
But for non-emergent services, it would be their policy. So I would encourage that if you're having difficulty getting a contract with one of the MCOs, that you let Jill know or let me know, so we can have a conversation with that MCO. We would like to see contracts with all the FQHCs in the Southeast Zone and with all 3 of the managed care plans. Okay, and I do appreciate that everyone is thinking about what we're talking about and sending in questions. There was earlier talk of capitation contracts for the CHC plans. Will this be the same expectation for FQHC contracts, given that we receive PPS per encounter? So I think what you heard, and I think what you're thinking about here, and you can maybe send in more detail, is around value-based purchasing. So health centers do a lot of services outside of the face-to-face encounters for PPS. It's really between you and the managed care plan to negotiate what additional services you would be willing to do. I know that for some of you that are doing the COE program, this population may also be seeking treatment under your COE. So there are different things that you're doing for the population in general. So you should be having that conversation with the managed care plan if there are things that you are doing for your health choices patients that you think might be beneficial for this population that's really outside of the face-to-face encounters.
And that doesn't go on the wrap.
That is correct. So anything that's done that's billed not as a T1015, and there's a lot of other things going on between managed care plans and the FQHCs, especially as on the health choices side, we've moved into a lot of value-based purchasing arrangements. Everything that's not billed a T1015 is not counted in the wrap and is not paid at PPS rate. It's paid at whatever your rate is that you've negotiated with that managed care plan. So I know for some of you that are running patient-centered medical homes, there's some PM amounts that you're getting to cover individuals that are attributed to you as a patient-centered medical home. That's something that's outside of the face-to-face encounters that may, if that's your arrangement with the managed care plan, be capitated, it's not counted, that revenue doesn't offset your encounters. So again, I'm going to pause. So those of you, if I didn't get your question exactly right, if you want to follow up with some additional thoughts, I'd be happy to answer more there. We understand that we should submit the T1015 code. Is it okay to include the specific CPT codes if requested by the payer, or should we only submit T1015? So a lot of the payers require additional coding because of HEDIS measures, and as Jill spoke about earlier, we do take quality very seriously. We do utilize HEDIS as our measurement tool. So a lot of the payers do require additional CPT codes. Some of them require that you bill 0 on T1015 and bill amounts on the CPT code, that you bill all your money on bill all your payment on the T1015 and bill some nominal amount on the CPT code. That doesn't matter. What you should bill T1015 in there. The mix of additional services is based on what you've agreed to with that managed care plan, and it's really needed for HEDIS purposes, and they should only be paying on T1015. So a lot of times we see that they pay 0 on the CPT codes and still pay your PPS rate on T1015. If a patient is dually eligible, Medicaid copayment is still collectible at the time of service. That is correct all the time. However, there are rules around what is required if they're unable to pay. So you should, if you have a specific question on that, you can send that in to my group and we will respond directly and maybe give guidance to the association. But if they assert that they're unable to pay their copayment at the time of service, there are rules around that.
Yeah, if you can provide that we can send it to everyone.
After we receive a Medicare payment and we bill the Medicaid HMO using the T1015, do we bill our full PPS rate or the PPS rate less the Medicare payment amount? You always bill your full PPS rate. And they're required to pay the current PPS rate regardless of what's billed. Now, often that gets us into trouble because we have lots of back and forth where funny things go on. We always ask that you bill your full PPS rate. Regardless of what they tell you, if your PPS rate is $100, bill $100. So we have a law. We can move on, and as I get more questions in, we can circle back to me at the end.